Welcome, everyone. Thanks so much for joining. I'm going to give folks just a minute or two to come on in. Wonderful. So welcome again. Thank you so much for joining. My name is Julie Erickson with the Office of Recovery at SAMHSA. If you aren't familiar, the Office of Recovery is charged with advancing recovery across the nation in partnership with people with lived experience, their families, and communities impacted by mental health and substance use conditions. I'm also someone with lived experience, lived expertise in mental health, and also as a family member. And happy National Recovery Month. National Recovery Month is a national observance held every September to promote awareness of the power of recovery from mental health and substance use conditions. In honor of Recovery Month, we encourage you to visit our Gallery of Hope, which is now available. It seeks to break down societal stigma and foster greater understanding and support. We also invite you to join us on September 24th for the live stream of our first ever STAR Awards. STAR stands for SAMHSA Trailblazers in Advancing Recovery, where we will be celebrating those who have significantly contributed to raising awareness about mental health and substance use recovery and wellness. We'll drop those links in the chat here momentarily. And finally, hot off the presses, as they say, we just released 4 new fact sheets today. 2 are focused on the LGBTQIA+ community and recovery. Another one is focused on recovery-oriented, person-centered treatment. And the last is called Know Your Rights, which is very applicable to today's presentation. So once again, thank you so much for joining. Today's webinar is an extension of a webinar we held in June on Psychiatric Advance Directives, or PADS as they're commonly referred to. And there were so much interest and even more questions, so we really wanted to hold another session, and we created our agenda today to dive deeper into some of the themes we heard in your feedback and in your questions from the last session. So our focus today will be legal questions related to PADS, the details of what to do with your PAD once you complete it, and training and on how to complete PADS. Next slide, please. Thank you. So audio is available through your computer or phone. If you haven't already, please do introduce yourself in the chat if you wish. You may also turn on closed captions through the CC icon at the bottom of your Zoom window. And please submit your questions into the Q&A box as you have them, so that we can easily find them at the end when we start Q&A. And lastly, we'll be sharing a feedback survey at the end. So please do try to fill that out before you leave today. Next slide. Just a disclaimer that the views and opinions expressed today don't necessarily reflect the views of SAMHSA or HHS, and we will be recording today's presentation, and so it may not be distributed for a fee without written authorization from HHS. Next slide. We have a number of amazing presenters today, and just a quick summary of our agenda. We'll start with a recap of what was covered in June, PAD basics essentially, and then move to our panel and then to Q&A as time allows. And it is my honor and pleasure to be able to introduce to you all Harvey Rosenthal, CEO of the Alliance for Rights in Recovery, who will get us started today. So thank you so much, Harvey, for being here and for lending your expertise to this topic. I'll let you take it away.
There we go. Thank you, Julie, and good morning, good afternoon, everybody. Unmute. Okay, can you hear me now?
Yes.
Okay, great. Good morning, good afternoon, everybody. So glad you're here. We had a great response to the last webinar, the first one on this, and we're so glad that a number of you are back to hear more about it, and some of you are here for the first time to hear about this because it's so critical. I would just say that the ever-growing interest in psychiatric advance directives really builds on a number of SAMHSA's core framework in the past, a real interest in self-determination and self-direction, a real focus on wellness and recovery tools, RAP, taking action, etc., a real focus on trauma-informed crisis prevention and response. And moreover, all of us share, I think, a desire to see that people are getting services in a voluntary way. And the PADS as a guide hopefully will really help that as well. Next slide. So this is a very small example of what we came up with last time. So the Psychiatric Advance Directives is a written document that expresses your wishes about what types of treatments, services, or any other assistance you may want during a personal mental health crisis when you're deemed unable to make or communicate your treatment decisions and preferences. It provides a clear statement of your medical treatment preferences, there it is, and other wishes or instructions. You can also use it to grant legal decision-making authority to another person to be your advocate and agent when you're unable to make or communicate treatment decisions until the crisis is over. Next slide. So a little research, there's a lot of it here. We just took a few points of it. So research has shown that people who complete a PAD tend to experience significant improvement in working in alliance with their clinicians, and resulting in fewer coercive crisis interventions and better correspondence between preferred and prescribed medications over time, and an increased perception that people's needs are being met and respected and recognized. And there's a MacArthur study that was funded in 2006 that identified that it was a large demand for PADS amongst people using mental health clinic services. Next slide, please. So we found some pieces of testimony from various groups about why PADS are so important. This is my favorite one, the person themselves saying, "The reason I worked so hard to get my own personal PAD in place was because I never knew when the day may come that I may not be able to make decisions regarding my own psychiatric health care. During the darkest moments, the PAD speaks for me by allowing me to be an active part of my treatment when I am not able to. It is a gathering of my wisdom put to its best use to share with my chosen supporters those decisions I've made regarding treatment, provider, visitors during a crisis." Family members, here's a family member quoted, that really provides some clarity, helps reduce family disagreements and emotional burdens by clearly outlining the family member's preferences, provides a sense of security and comfort by making sure the family understands what their family members and wishes are known and that they're respected, and that they also really can improve communication in general between the person and their family and the treatment team. Next slide. Here's a clinician saying they really can help convey information among key actors to optimize crisis treatment process and outcomes. PADS can help clinicians understand how to best support a person during a crisis and who to contact about their mental health care. Then he says, "I have seen so many people in crisis with no plan in place, which leaves them vulnerable and stuck in a place where it is far more traumatic for them. And trauma-informed, the PADS offering a trauma-informed way to respond to people is critical." Public defender says here that the PADS and healthcare powers of attorney make it possible to avoid pain, coercion, forced medication, solitary confinement, jail, prison, hurt or broken relationships, poorer health, and worse. They recommend them to anyone even remotely affected by mental illness, addiction, trauma, dementia, or any other health condition where symptoms could result in a hospitalization at a psychiatric facility. Next slide, please. So Luke and I are working in New York. I'm the CEO of the Alliance for Rights and Recovery here in New York, and Luke is our public policy director. And we've been working with the state of New York, the Office of Mental Health, on revising the tool and making sure that it's available and used. So we're really following 4 real guides, and they were talked about in the last in the webinar, that the tool be user-friendly. We're revising ours, that it be really clear, concrete, and culturally responsible for the person in particular. That there be a funding stream, because peers supporting each other to fill this out is really critical. But in some cases, you'll need a funding stream for that to happen. We do have that in New York in general. That the PAD, and this is a key one, the PAD is widely understood and sought It doesn't matter how good a tool we have if nobody knows it exists and they can't find it, and they don't use it. So, and frankly, that's often the case. That's the majority of times. We have a lot of work to do this, to make sure that they're widely understood and sought, that there be extensive training and TA programs routinely included in academics of curriculum, providers, police, judges. You'll hear more about it later from our wonderful presenters. And finally, that it's accessible. A number of us here think that a critical time and place is if you're in the emergency room when decisions may be made that you really either will like or not want, that your wishes, if they're kept in your electronic healthcare record in the chart, that the folks in the emergency department will look for. That's a critical time and moment. But you can, it can be electronic healthcare records anywhere, and even LegalZoom is a place where you can find it. So I'm going to turn this back over to Luke Sacchini, our wonderful public policy director.
Thank you, Harvey, and thank you all for joining us today. When we talk about psychiatric advance directives, I think sometimes at the top level view, people often wonder what actually happens when you're using these and how to actually use it, and what's the experience like for people when they're using it. So luckily today we have someone here who can talk extensively about their own experience using a psychiatric advance directive and creating one and how that helped them. So I'd really like to welcome Kaylee to come let us know how this has been useful in her life.
Thank you so much for that introduction, Luke. And can we go to the next slide, please? So on here, you'll see that there is a picture of my mother and I on my 18th birthday. And although you can't see from hiding behind the cupcake, I was pretty annoyed that she made me take this picture with her. However, now looking back on it, I'm grateful to have it. And to start with my experience about what a pad felt like in using it, I'd like to begin with a background on why I created this. When I was 18 years old, I experienced a mental health crisis that led to an inpatient hospitalization. While I was there, due to the nature of the crisis that I was experiencing, I wasn't able to clearly communicate on my own behalf. A lot of the information and just things that I wanted to say weren't coming out correctly or were a little bit jumbled and disorganized. So with that being said, there were certain decisions that had to be made where I was not able to advocate for myself or have much of an input on some of these decisions. And although some of the treatments I received were helpful and were in my best interest, there were also treatments that I experienced there that I really feel were harmful for me. And through that experience, I felt very disempowered. I felt like my trust had been damaged, and it left me feeling afraid of the mental health care system and afraid to seek out treatment in the future. When I was discharged from the inpatient stay, I stepped down to a partial hospitalization program. I was able to go home at night and go home on the weekends, and I had a lot more autonomy and was able to start making decisions again on my own behalf. I can honestly say that that was some of the best treatment I've received in my life. While I was there, one of the activities that I did was completing a psychiatric advance directive. This was something that the staff there and the clinicians brought to my attention. And the first part of it was my instructional or my written wishes, where they gave me a piece of paper that had different prompts and questions. I was able to write down things that did work and things that I did like, as well as things that I felt really weren't helpful for me. Through that process, I really felt that it started to repair a lot of trust and build back some of my faith in the system, because I'm in this environment where not only do these clinicians wanted to hear what I had to say, they also wanted to support me in expressing that so that my voice could be heard in the future. Another part of the pad that I created was granting my mother my power of attorney. And with that, it was a big decision for me to make, but she has always been my number one advocate. She has always been in my corner through thick and thin. So for me, that was the natural decision to give her that power where she was able to speak on my own behalf if I was back in a similar situation. With that being said, I unfortunately did end up back in a similar situation where I had a crisis that resulted in a hospitalization. And again, because of where I wasn't able to communicate or to make decisions for myself. In addition to experiencing the mental health crisis, I was also dealing with an infection in one of my organs. And while I was trying to explain that to the staff, because of the mental health symptoms that I was having, it what was going on with my body that I was trying to tell them about was written off as another one of those mental health symptoms. But with my mom being someone that knows me very well and being someone who is a registered nurse, when I talked to her on the phone, she knew exactly what was wrong. And through her having that legal document as my power of attorney, she was able to get the medication ordered for me to treat the infection. She was able to have the proper lab work ordered for me as well. And I started getting a lot better once the issue with my body was taken care of. So I can genuinely say that with this infection, if it had been left untreated, I don't think I would have been able to communicate that. And there is a very real chance that I would not be here today. So not only did having this psychiatric advance directive be able to give me back my voice in crisis, but it is the reason why I have my voice right now speaking on this panel. And at the bottom, there is a link which will be sent out afterwards. It has a film with me and my mom talking a little bit more about that process and answering some different questions about how this document really strengthened our family dynamic. But yeah, with that being said, I will pass it back. Thank you for letting me share.
Thank you so much, Kaylee. I think that really gives us a great example of how psychiatric advance directives can be used and how that process itself is part of that recovery journey, being able to really consider what aspects of support and treatment that you would really want and are helpful for you, but also being able to have those conversations with people you're close to, like your mother and other family members and supporters, to be able to be there for you in those moments of crisis and ensure that your wishes are kept. So when we think about this, I also think it's important to consider how PADS have that legal right, the history of them, what sort of legal considerations need to be thought of when you're completing them, and then how they're actually used and accepted into when we're talking about, in the emergency rooms and in these crisis situations. So today we're really lucky to have two wonderful folks with us, Dr. Marvin Schwartz, as well as Marjorie T. Schur, who can speak to us a little bit about the history of these psychiatric advance directives, how they came to be, what the legal considerations are, and then what their usage is, and sort of the limitations that are there that are really important to know when you are completing it and using it. So I want to start with Marvin to tell us a little bit about how psychiatric advance directives came to be.
Thanks very much, and it's a pleasure to be here. My group operates the National Resource Center on Psychiatric Advance Directives, and I welcome all of you to go there if you have questions about your specific state or have interest in other aspects of PADS. We've done a lot of the research that Harvey mentioned and have been interested in the development of PADS across the country. Next slide, please. So psychiatric advance directives are legal documents, and there's two components, as Harvey mentioned. One is the instructional directive that allows a person, when of sound mind, and that's in air quotes, to refine or give consent to future psychiatric treatment. That's called the advance instructions. And I say of sound mind because that's the principle behind a lot of things like wills, and other documents, that it presumes the person knows what they're doing, they have clear a clear head, and the role of the person who witnesses is to attest to the fact that the person's of sound mind. The other aspect, as Harvey mentioned, is the authorization of another person to make future decisions about mental health care on behalf of the person executing it, if that person loses the capacity to make and communicate decisions. The goals are to empower the person, even when they can't speak to themselves, to direct their care. And so the construction of the Psychiatric Advance Directive is the ability to say, if this happens to me, and usually happens to me, they've had an experience and they would like it to go differently, the goal is to state their treatment preferences during a crisis, and if they wish, to empower a trusted person to make decisions for themselves. In most states, you can have one or the other or both, but I don't believe you're required to have both. So you could just have a standalone written advance directive or a standalone healthcare power of attorney. But we recommend that people have both, because it's much more powerful to have a person, if there is a person you trust and would like to empower, it's much more powerful to have that person speak to your preferences during a crisis, because there's many instances, just as with living wills, where situations come up that aren't in the written document. So where'd they come from? Well, this goes back to the Supreme Court decision in the Cruzan versus the Director of Missouri Department of Health. And this was in the 1990s. What was happening then was that Nancy Cruzan was in a persistent vegetative state. She'd had an accident and had extensive brain damage, and she was on life support. And her family knew that Nancy did not want that for herself, and so tried to petition the hospital and the state to take her off life support. And the hospital said, well, we don't have any evidence or clear evidence that this is what she wanted, and we don't have the authority to do this. And the state sort of held their ground in that and said, we can't willy-nilly take people off life support. So when this got to the Supreme Court said, yes, people have a right to self-determination. They have a right to stop life-sustaining treatment. But there needs to be clear and convincing evidence that that's what they would want for themselves should they get into that kind of situation. And so in that Supreme Court decision, they said, yes, people have a right to self-determination and the right to terminate care, but there has to be clear and convincing evidence. And that has taken the form of living wills. And the Congress, in fact, passed a year later the Patient Self-Determination Act that helped to implement medical advance directives and end-of-life living wills. And it requires hospitals or institutions taking federal funds to ask patients if they have an advance directive on admission, document their existence, and follow them, and have written policies for implementing psychiatric advance directives. Now, the mental health community and mental health advocacy groups saw this as an opportunity to adapt them for use in mental health care. And so starting in the late 90s, states started writing these psychiatric advance directive statutes, which had an additional feature that the person bound themselves to the decisions in the PAD if they had a period of incapacity. There was a recognition that often, or sometimes at least, people in crises make decisions that they otherwise wouldn't make. And what the PAD does is binds them to this set of decisions. Now, that aspect of a PAD, this self-binding part, is a little bit controversial. In some states, such as the state of Washington, has written their statute so that a person can choose whether to make their PAD self-binding or not. Now, just to be clear, even in states that don't have these standalone psychiatric advance directive statutes, usually, and with only a few exceptions, those types of instructions that would go into a freestanding psychiatric advance directive statute can be written generally into the general living will and healthcare power of attorney provisions. Some states don't allow the full the full decision making that's in a psychiatric advance directive, but the result is that in every state, even if you don't have your own PAD, and I think there's now 28 states that have these set-aside psychiatric advance directives statutes, that you can create one of these. So effectively, these have spread so that you can use the existing or the standalone psychiatric advance directive statutes to implement a psychiatric advance directive. Next. So how do you do it? So any person during a period in which, you know, they really can step back and reflect on their experiences with mental illness and what they would like in the future, can draft an instructional directive. And they can put things in there about their preferences for medications, for what kind of treatment program they'd be on. They can give helpful instructions about what sorts of things help them. They can put in there anything that they think would be helpful for their treatment. Although the sort of the decision-making part has to do with things that they would need to consent to. And the instructional directive then has the power to make those treatment decisions during periods in which someone's deemed to be incapable, during periods in which they're not able to make or communicate mental health decisions. What does incapable mean? Because that's a critical thing in these statutes. What it means is that the person has been evaluated by a provider, and the provider has said, and here's how it's framed in North Carolina, in the opinion of a physician or eligible psychologist, the person currently lacks sufficient understanding of capacity to make and communicate mental health treatment decisions. So from that, and the provider just writes that in the medical record. This is not an incompetency determination. Incompetency is when someone goes to court, presents evidence to a judge of a person's inability to care for themselves, and the judge determines whether the person's has incompetency and appoints a guardian. This is an informal medical decision whereby once the physician writes it in the medical record, the person's deemed incapable, should not be making treatment decisions until they regain capacity. The regaining capacity is when that person then writes in the record the person's regained capacity. Again, this is not a court process. This is a clinical process. Now, the next question that comes up is, so must the clinician always honor the advanced instructions or the directions from the healthcare power of attorney? And generally, there are exceptions in states they do need to honor them when the person's deemed incapable, but there are exceptions. And generally, the exceptions are that the clinic, if the treatment isn't available, for example, if the person has to go to a hospital that doesn't have any beds or can't take the patient, then the clinician just documents in the record that that treatment preference was not feasible. The other main exception is when the treatment being requested really doesn't comport with community practice standards. So say the patient in their advance directive asks for something that's contraindicated, that wouldn't be good for the patient. And the clinical team says, well, we really don't think this would be in their best interest. A simple example might be a patient who had written a pad a year ago has become allergic to that medication. Well, the clinician would document in the chart, well, even though this is in the pad, we don't think that this is in the patient's best interest. There's also certain emergency situations or involuntary commitment that would trump this. Now, let me turn this over to Marjorie, and she can comment further on these issues because they're important.
Thanks, Marvin. Yeah, I think that you covered really well what we see in a number of states. Like you said, states have individual psychiatric advance directive statutes. So just for sake of transparency here, I'm going to be speaking from the perspective of Georgia. I took a close look at Georgia's statute, and I feel like it's instructive to kind of give you all like a sense of what's in a typical PAD statute. And so the first thing that's interesting in the Georgia PAD statute is that it says that upon being presented with a psychiatric advance directive, the provider or the facility shall, so they have to, make the directive part of the medical record. This goes back to what we were talking about earlier in the presentation about where does a PAD live. And so if you're in the state of Georgia and you have a PAD and your PAD's in the medical record, I think it creates a little bit of a sense of security that your PAD will be able to be found, because theoretically, once it's part of the medical record, the providers to adequately prepare for providing care should review the record and see the PAD before actually providing care. This is not something that's part of all state statutes. So I think that that's one thing to just keep in mind in preparing your PAD and educating yourself about the PAD in whatever state you're in. Next, like Marvin was saying, the statute does require that the provider or the facility comply with the directive unless there's sort of a reason not to, right? So the rule is comply. The exceptions are do not comply under certain circumstances, one of which, like Marvin was saying, is the treatment's unavailable. One is that they're medically contraindicated. I think an allergy is a great example. A physician has discretion, a physician has a responsibility to do no harm. They have their own legal and ethical obligations. So knowingly providing someone with a treatment that could be detrimental to them, could cause them significant side effects, would likely fall within the realm of that discretion. And then the third, and this is the grayest area where we would potentially see disputes, is just in the opinion of the provider or the facility that whatever the preference is inconsistent with medical standards. And I think we're going to talk about this a little bit later on in the presentation. That's where education about the PAD, education about clinical standards, acceptable standards, might come into play when creating your own PAD. What I've seen in Georgia's statute and a couple of other states, which if I were taking notes right now, I would highlight and underline, is that overriding a PAD is preference by preference. That means that a physician does not get the discretion to override a PAD writ large. They have to go preference by preference and find a justification for overriding each one of those preferences. So just to sort of ground you in the actual statutory text, it says, in the event that a part of this directive is unable to be followed due to any of the circumstances, all other parts of the directive shall be followed. Interestingly, also, there are in many states an obligation for a provider, if they're unable to follow a piece of a PAD, to try to transfer the patient to another provider or a facility if the requested care could be delivered. Probably this comes into play mostly when care is either available or unavailable, potentially based on specialty, based on therapeutic modality. I would imagine that standards of care, and Marvin, please feel free to jump in if you've seen differently, I would imagine that standards of care are uniform enough across providers that if a preference is like wildly inconsistent with the standard of care in one facility, it's likely not going to be consistent with the standard of care in another facility. So I think that that's really meant to try to address the availability of care. And the last thing that I think we've touched upon, and probably is one of the biggest limitations to PADS, is that a psychiatric advance directive shall not limit the involuntary examination, treatment, or hospitalization of patients pursuant to Georgia law. So if you are hospitalized, if you are receiving treatment pursuant to a civil commitment, that's sort of one of the biggest umbrella areas in which a PAD can be overridden.
So I think that, go ahead.
Oh, I was going to say, I think that's sort of the statutory overview, but I think it is interesting to think about how the culture, I guess, of healthcare facilities exist to complement maybe the statutory language. So like Marvin was just talking about, you do not need to honor a PAD until a person's found to be not incompetent, but incapacitated. That being said, a PAD is a wonderful source of information at any time in the treatment. So someone walks into an emergency department, you've not been yet declared incapacitated, you've not yet received that examination from the clinician, but an ER nurse, an ER physician who's ever checking you in can say, hey, do you have a PAD? Do you have an advocate? And use that to sort of inform the care throughout the course of the treatment, even though they're not legally obligated to do so.
So I think one of the big benefits that of a PAD that's implicit in what Marjorie is saying is that if a person, say, comes into the emergency room and they're not able to consent to treatment, which is a requirement, a patient has to consent in order to be treated. Usually a clinician would have to involuntarily commit the patient to proceed with treatment if they can't give consent. And what a PAD does is gives authorization for consent via the advance instruction or the proxy through the healthcare agent. And so what we like to point out is it's a great tool to avoid involuntary commitment, which is obviously something that is really stigmatizing and disrupting to care and upsetting to people. So we try to say one of the key benefits is it's a way to avoid involuntary treatment. Just a minute on healthcare power of attorney. The healthcare power of attorney is generally appointed in the same way as you write in advanced instruction. One caveat is that that person can't be a provider. They can be anyone that the person trusts that's over age 18, but not a provider. So you can't appoint your doctor or your therapist or someone else. That person is appointed, and that person has very broad powers in that that person can consent to anything the patient would consent to. So they then become the mechanism to consent to any form of treatment that is being recommended. So it's clearly someone that the patient has to trust. And also the role of that person is to interpret the preferences of the patient, not to insert their preferences. And that's a key thing that people sometimes misunderstand. It's not their job to figure out what they think the best interest of the patient is. It's their job to interpret what they understand to be the wishes and values of the patient and convey that to the providers. So let me stop there and we can go on to the next slide.
Right. Thank you both. That is incredibly informative. And I know, thinking about those legal aspects, it's really important for us to know about that while we're both completing a psychiatric advance directive. And then, after we've completed, knowing how it's going to be reacted to from those clinicians, from the other folks who will really need to see that. But going on, thinking about, we have in this situation, we've completed a PAD. We want it to be used, but what do we do after we've finished creating one for ourselves? And have our family members or other supporters know about it. We're going to talk a little bit more about that because I think this is a really critical step to ensuring that they're actually followed. And today we have with us Rachel and Kieran and Ryan, who are going to talk a little bit about the process of what we do after completing this pad, and starting with Kieran and Rachel.
Thank you. So actually, you'll just take you to the next slide. Oh, actually, well, okay. Well, actually, I'll start here. So we're from California, Rachel and I, and we work on a multi-county project. So in California, actually, the new stats just came out. We spend the most of any state on mental health treatment. We spend $6.5 billion a year on mental health treatment. And if you are incarcerated, it's $120,000 per year per individual incarcerated who needs mental health care. So the state of California, we have something that's unique. We have a millionaire's tax. So 1% of anyone making over $1 million goes to a special mental health fund that then gets trickled down to the counties. It has recently changed. The counties will be receiving a little bit less funding. As part of that funding will go towards housing, because we also have, as you know, a very large housing insecure population in California. But our multi-county project used what we call our Mental Health Services Act funding to create a collaborative. And currently in phase 1, we have 7 counties, and phase 2 rolls out next year. And we are already having some more counties come on board, and we're always welcoming counties in California to join the phase 2 rollout. But if you forward to the next slide, we'll tell you a little bit about what we're trying to do in California, really looking at innovations, because exactly as you've already heard today, what happens with a pad? You fill it out, and then what? And part of the problem in California, for one, is they really are not widely used, and they're not widely recognized. I've spoken to psychiatrists who simply say, oh, we don't ask for it. And that kind of goes along the lines, and what we're learning in the project is it's not just psychiatric advance directives, but it's directives in general, whether it's the PULSE, whether it's the advanced healthcare directive, whether it's the advanced healthcare directive with mental health components, or whether it's a standalone psychiatric advance directive. Widely in California, they're not used. And so our project is really looking at how to change that and how to move paths forward in California. And Rachel, if you could talk about how you led and how Painted Brain led the peer process in an iterative process as we created our standard form.
Yes, thank you. I'm so honored to be here. And I always like to start it off by saying it's one of the most exciting times in behavioral health reform and civil rights advocacy for peers to be involved in this work in psychiatric advance directives. I was honored to lead our organization with our amazing counties and engaging in, for about 7 months, listening sessions that really honed in on the needs that the consumer, that the peers thought would be most important, that hospitals, that law enforcement, that clinicians would need to know most about their care. And so we really set out with a pretty assertive goal to capture what we believe has been like these amazing categories that really spell out the core components of what we as peers, consumers, believe are the categories that we want those individuals that would serve us to be known, particularly our medical conditions, accessibility, our crisis support, who's going to take care of our pets and dependents, decisions about paying the rent, reproductive health choices, gender affirming treatment, just a number of different categories. And as myself, with peers, as Kieran said, leading as the backbone of this project, we really were able to inform the categories in our electronic psychiatric advance template because of our lived experience, because I've been hospitalized, as Kaylee has said, and had a medical situation at the hospital and know too far well of what happens when your voice and choice and is not known, not because of maybe someone's fault during treatment. So yeah, I believe that we were really intentional in California and really setting out to do our digital pad categories. And I don't know if Karen wants to add any additions. We did a lot of other areas, but specific to these categories, we really focused on that. And I don't know if you want to add to that or go to the next slide.
One of the aspects, and we're going to talk a little bit about the innovative part that we're doing, is that digital, because what we've heard not only in California, but nationwide, and even in speaking about pads within other countries, is where do we access them? How do we get them? And yes, Marvin specifically even sent me information on the fact that our 42 CFR specifically states that we need to have a registry, right? So everyone, based on federal standards, is supposed to have a registry. Well, our system is very archaic, and unfortunately, you can put information in a registry, but it kind of gets lost, and then a hospital that asks for it only gets identified that, yes, this person has the document, but they don't get the actual document. They don't get the information. So we really are looking at the fact that, I admit it, I'm the last generation born without technology. Every generation after me is so technically savvy, and they're asking for, I just want to fill out a pad at home, or I just want to fill out a pad with my peer support specialist, or I just want to fill out a pad while I'm sitting in the park, or at school, or wherever it is that they want to fill out a pad. And we look at that with our TAY generation, especially our transitional aged youth, that are looking for a document that's going to follow them through their lifespan and can be easily changed. So one of the aspects, Richard is our model. And really what we wanted to showcase for hospitals, for law enforcement that's touching on an individual, is Richard is, this is what Richard looks like when he's not in crisis. And we really want to humanize the individual and say, look, just because I'm in crisis, this isn't who I am all the time. And so how do we really bring somebody to baseline a lot sooner? And then just one more on this slide is our peer organizations, and all our peers and our work groups created our logo, Psychiatric Advance Directives, My Plan, My Voice. So in California, we really are trying to promote recognition also. Next slide. And when we look at the reasoning behind an electronic platform, it's exactly what Marjorie and Marvin were saying, is we don't necessarily just want to wait for someone to lose capacity. In California, we really push our law enforcement crisis intervention teams. If someone's in crisis, we say, ask for a CIT officer, ask for a CIT officer. So a CIT officer shows up and they are completely blind to the situation. They have no idea what's happening. And so if somebody has not lost capacity yet, or if somebody has a preferred contact, or a family member's with them, or a neighbor's with them, they can say, this person has a pad. And so we are looking at, with permission, I mean, everything's based on consent, because as you've heard, a pad is voluntary. A pad is owned by that individual. And so the users on our electronic platform would have accessibility to say, I don't consent to anybody having this information. But what law enforcement has said is, look, we don't want all the information. We just really need to know, are they on a medication that we need to know about? Do they have de-escalation techniques? To what Rachel had mentioned, do they have a child that needs to be taken care of, or a pet that needs to be taken care of? And so same with going to the hospital. Are there medications? Are there allergies? So what we're also looking at is, how do we get the best care coordination also? How do we call that preferred contact? How do we avoid 3 days in a hospital and no hospital bed, no IPU beds, and no other inpatient beds available in California, what we call jello therapy? How do we avoid that and bring somebody back to their baseline much sooner? Or if they have lost capacity, how do we understand those preferences? And what are we missing is training. Training. It doesn't matter if you fill out a pad in California, if the hospitals are not trained, if the first responders are not trained, if the peer support specialists are not trained, and the crisis teams are not trained. And in California, we also have the mandate, which I believe is across the nation, is our mobile crisis teams. Really looking at, we have to train people. What does it mean when you ask that somebody has a pad? How do you utilize those preferences? We should be able to use those preferences as tools, not only in that lost capacity, but prior to lost capacity, and how amazing it would be to reduce the recidivism and that negative effect of the interactions with law enforcement. Why do we want generational trauma? How about we change that message and change that narrative now as we look at moving our digital pad forward in California? Rachel, if there's anything you'd like to add?
Yeah, I mean, you got me excited because I want to just end on a couple of points that, like you said, that generational trauma, like it just brought up my son that is on the spectrum, that is the most brightest young man. And, but does he have the ability always to express, and and in a crisis, do I want him to have every tool at the right moment, at the right time that can best protect him and for him to grow? So that resonated. And this is a human rights issue. It's a civil rights issue. And I was talking to Karen about thinking of this as a whole health integrated approach to care, using all systems approach on deck to provide the most informed care for an individual is really, as an advocate, is what I believe in. And I believe that you all on this call believe in as well. And so I know we'll transition to training, but just to uplift us in California, and inspire you all across our great nation to begin to start training, to begin to start hubs of education, begin to advocate, begin to use the peer support specialists across our great state to mobilize, to get us billing, to increase our workforce. And thank you, I appreciate it. Oh, and more calls to action. Wait, I was getting too ahead of myself. That's why Karen's like, yes, yes, yes. All right, go ahead, Karen, and then I'll keep going.
No, you got it, sister. I love that. Obviously, we love our PADS project here in California because we really want to uplift directives. We want to uplift the fact that you should have, if you're going to fill out a standalone pad, make sure you have a durable power of attorney. If you're going to fill out the pulse and really, again, we want to create that seamless whole person when we look at our care. So we are looking at how do we address our repository concern? How do we tap into our electronic version and creating those MOUs with hospitals and the risk managers in hospitals as well? How do we tap into our law enforcement and our first responders, our paramedics, so that they get just the information they need in the moment to work on that proper care coordination? And again, to Rachel's point, really looking and humanizing a person in totality. So that, I think, is all we have to say right now on the California project. But we really hope that all of you across the nation will uplift psychiatric advance directives within your community. And with that, next slide.
Wow, thank you all. We also have here another example of pad storage coming out of North Carolina, and I believe this was coming from Marvin and the National Resource Center. So a number of different ways that we do this, but I have to say, the California folks, you guys are getting me really excited about what the possibilities for the expansion of the use of pads, and really that training piece is critical. And we do want to drill in on that part a little bit more, thinking about not just all the folks that we need to train. You've heard from Harvey, Kieran, and Rachel, and Marvin talking about training folks in emergency rooms, emergency dispatch folks, mobile crisis teams, police officers, folks who might be interacting with people who might be in a crisis, making sure that they understand how to recognize pads and how to implement their usage, but also thinking about how we train folks to help other folks create their own psychiatric advance directives. So looking at how we can effectively train other peers to help and support their community members and other folks who are interested in creating a psychiatric advance directive to do so and understand what it's going to mean for them. So today we have a couple other folks, who can talk to us a little bit more about the training. And I want to start with Ryan and hopefully talk to us a little bit more about the training that the Copeland Center has been utilizing to help spread the usage of pads.
Great. Thanks, Luke. And thanks everyone before me. One thing that we've done at the Copeland Center is really leaning into this process of peer-supported psychiatric advanced directive trainings and really talking about, we like to come to everything with personal lived experience. So how can we do that while having these conversations? And so you can go to the next slide. And so one thing, that's really important to mention is when we come into these processes, we really reiterate that everything is individualized. Everyone is the expert, of their own process and of their own selves. So when we talk about, advanced planning, it's really an act of that personal responsibility. We can guide that process. We can have a lot of conversations and we can support that learning. But ultimately remembering that, each person is individualized and people can be a part of this process, but not actually create that hard copy plan. And that is okay because it's just about exploring these processes together. But also really talking about how, these advanced plans can really be an expression of personal hope. So oftentimes, people come into things and, they might just feel like they're a little bit lost. And, we hear that people come to workshops oftentimes feeling hopeless. And so being able to sit down and ask people questions around, what's working for you, what's not working for you, that I think in turn creates a little bit of that personal hope because people are able to kind of start exploring themselves, figuring out those answers in their own lives. How does that really incorporate into their personal life? And so I think it really brings this expression of personal hope as well. Just moving along this graph here, I think it's really important to mention to people that this is also a little bit of a social responsibility. It's a responsibility to ourselves, but also it also ultimately supports our supporters. It supports any doctors and any type of system or professional people we might be working with if we go through a crisis, because we might have answers already there. We might have thought through those things and, it's easy to say, great, I've looked at this person's plan and they have outlined X, Y, Z. So now I don't have to ask, this list of 10 questions to get to that answer. And then ultimately, it's really an extension of self-awareness and self-advocacy. Going through this process really allows people to, one, become a little bit more self-aware of how things might show up in their life, but also it creates that avenue for people to self-advocate and say, actually, no, this is exactly what I want and need if I'm in a crisis. I know myself best, and I've created this plan to do so. And so these are all just some points that we really like to start off with. It's just really reiterating that this is individualized, we can do this process together, but ultimately it's up to each person to decide what that plan looks like, or even if they decide to create a plan after that peer-supported group. So you can go to the next slide. So we talk about, peer-supported paths courses, but what exactly does that mean? So for us, being able to sit in a peer-supported group, that means one, we're just exploring a lot of different perspectives. There's so many times that, I've been in a group and somebody says something and it's like, oh yeah, I do have previous experience that lines up with that example that I might have forgotten about. Or, what, I definitely thought that might have been something that was too small to list in my advanced directive planning. But, I've heard some people talk about it and actually maybe it's not too small of a thing to list. So it allows people to really get that individual insight around like what's going to work, what's not going to work, and just to hear that from other people as well. One thing that's really important in these processes is that we make sure that there are no wrong perspectives. Absolutely every perspective that comes in that room is equally as valid. Because again, each person is individualized. They're going to have their own experiences. They're going to have their own lived perspectives, and being able to support people to really have that self-determination to say, actually, no, I am going through this process. This is what I need. This is what I want. And again, all of those perspectives are valid. There's not a single wrong perspective in that room. And again, this course uses personal peer support and personal sharing to really come to those conclusions around that self-discovery and about our health. I will say that we're really adamant in these rooms and in these spaces to let people know that, we're just identifying plans. We're having important conversations around sections of a legal document, but we're not creating a legal document in that process. And we encourage people to say, no legal advice is going to be given, but we do encourage you to, after having these conversations, when you're feeling comfortable and you feel like you have that support, to then consult legal counsel of your choice. And we do that because, people can come to this process with different goals. Not everyone sits in a peer-supported paths course with the outcome intended to create a psychiatric advance directive. And of course, we really encourage people to do so, but that's valid as well. And so really letting people know, like, no legal advice can be given. We're going to support a conversation. We're going to support a process. Please, if you have questions or thoughts or concerns, let's talk about it as a group. But ultimately, like, if you're going to create this plan yourself, we do encourage you to seek your own legal counsel in the state that you're currently in. And then, of course, everything that we do in the Copeland Center, especially when we're talking about something around things that are really personal, we talk about crisis. All participation is voluntary. We will benefit from our sharing our own experiences, but everybody can dictate what that looks like. So just showing up to the course and sitting in the room is really supportive of you in terms of creating that plan, thinking about what that looks like moving forward. We want to support that. So all levels of participation are voluntary, all participation anyway. We do make sure people know, you're here, you can participate at what level is going to work for you. And I think I have one more slide, so you can go ahead and move to that last one. The last thing I want to talk about is we have this thing called the ASR model. I'm really talking about the role of supporters. And so when we mean ASR, we just start off with, the A means ask. So simply just asking people, do you have a psychiatric advance directive? Do you have any kind of advance directive? Where is the copy? Where are your copies? Where is that stored? So ultimately just starting the ask, do you have one? Afterwards, they might say no. So that means we're going to support here. And that might look like just asking people, have you heard of a psychiatric advance directive? Are you interested in learning more about a psychiatric advance directive? And so, this is an area where, you might get a yes or you might get a no. And it's really important that, this is individualized. So people have to make that choice themselves. And if they say no, that's okay. We can come back in a month or two and just say, hey, have you thought about creating a psychiatric advance directive? Do you want any more information? And until they say yes, we can just keep coming back to that support. Just every once in a while, just checking in. Is there anything that you want to know? Have you thought about it? But ultimately, this is an area where in order to go around the circle, they need to say yes themselves. So we can't make that decision for them. And so, great, they say, yes, I'm interested in creating a PAD. So then we move to the advocate. So sometimes this might be an area where different supporters might have different roles. So sometimes this might be, hey, where are all your copies? Does everybody have a copy? Does your doctor have a copy? Does your patient advocate have a copy? How can I support you if, something's happening that you need to advocate for? And so this can be an area where there's just a lot of conversation. And there's a lot of room here. And then lastly, this just brings us to revise. This is definitely an area where you can sit down with your supporters and talk about things together. This is what I might have learned when I went through my crisis. Actually, I realized that I do need to adjust my advance directive to include XYZ medical things or XYZ things in terms of psychiatric health. And so this is an area where, again, supporters might be able to help and say, okay, great, but how do we change this legal document? And this would be an area where you might have to seek out whatever state you're in, that legal advice for how do I legally change my psychiatric advance directive to support what I know now. And so this is just a brief overview of what we do when we talk about peer-supported PADS courses, why it's really important to have these conversations. But I also think it's really cool because people leave talking about more things. So people might sit down to create that document after they leave the group and they get left with questions like, why doesn't my state have a peer respite? Or, why doesn't my state have XYZ? And I think that that's really important in terms of a movement as a whole, because it gets people thinking even further of, great, I've created this document, but how can I create more avenues to have more choices and options? So yeah, I'll just leave it here because I know that there's more people on this call who can share a little bit more about training, what that looks like. But yeah, that's just a little bit about what we do at the Copeland Center.
Thank you so much, Ryan. This is wonderful work that you all are doing, and really excited to see more folks be able to take those peer-supported psychiatric advance directive courses. While thinking about training, we're talking a little bit here about training folks on how to complete a PAD, but thinking about sort of what we were talking about before about training folks on the other side of things at how to interpret a pad and how to respond to when that is there. I wanted to invite Kieran and Rachel back here to talk a little bit about their work in California around training of some of these providers and other folks who are, key stakeholders when we're talking about the usage of pads.
Rachel, why don't you go first with regards to the facilitation training?
Yes. Thank you. So just to highlight again, opportunities like the Copeland Center or other folks of training, Painted Brain supported the 7 County project to develop a PADS facilitated train the trainer training to support individuals with helping others develop a PAD. So we went through, I think the training is, tons of modules, and I don't have all the specific sections, but they cover a lot of the sections that are in the previous slide that we discussed. And then we don't provide legal advice, but there is guidance that we got from legal aids, and as much general information that we can get. We do provide it in our peer facilitated training. So I think that there's multiple modalities of providing the training. Our goal is to help an individual complete a PAD using the digital tool. So that's our framework, but I definitely want to lend it to Kieran to talk about any other aspects of the training and trainings that with other stakeholders.
I think one of the great aspects of being able to work on an innovative project and looking at a statewide change is that we are constantly evolving, and where we really wanted to come, full force and demand that everybody use a pad, we did realize that we have to really first inform, because it doesn't make any sense even for our CIT officers to say, well, what is a pad and what do I do with it? And even someone filling out a pad, what are my rights? And there's so much, it's not even just misinformation. There's misinformation, there's lack of information, there's lack of understanding. And so when it comes to training, we're really looking at it as more of a rollout. And so when we talk about rolling out the live product, we will be testing our digital platform. So we've already created the platform. We've done the build phase. We're beta testing it right now. We really are understanding that having that peer facilitation, so training more peers, is really working when it comes to filling out the pad and identifying with somebody what didn't work for you in your encounter with hospitals or first responders, and what do you really want people to know in that moment. So that, as Rachel was talking about, that peer training. But then we also are really recognizing information then comes second, right? So information on the providers that are going to access it. So we're working with the hospital, at the state level is really where we have to do some of that work. The California Hospital Association, the California Paramedics Association. We're working with our risk managers and going to conferences and really showcasing PADS, working with NAMI. And so working with NAMI California, Rachel and I are presenting at NAMI California. And part of what we've understood in this whole process is we don't want to do a knee-jerk reaction. If somebody wants to fill out a pad right this minute, we encourage them to fill out the current paper pad that we have in the state of California on the NRC website. But if they want to work on the digital pad, currently we are piloting that in our participating counties only. But in order to do that also, we want to make sure that we are reducing the recidivism. So we have to create the MOUs, and we really need to train law enforcement. If you encounter someone, ask them if they have a pad. Show them that logo. Do you have one of these? If you don't, give them a flyer that says this is where you can create one. But a lot of times it's that interaction of even asking someone, do you have a pad? That should be the first question. We want to connect with 988. How do we do that? We want to connect with 911. How do we do that? And so we are looking at connecting on those larger systems and training dispatch to ask, do you have a pad? And so as you can see, there's multiple levels in order to really uplift the use of pads to make it viable that when you fill out this document, whether it's digital or in writing, somebody's going to ask you and they're going to know what to do with it. And so that's what we look at with training. Rachel?
Just the last point, and I'll give it back to you, Luke. Is that the role of the peer supported training will be the most key. And as a call to action, once again, thinking about in your state, how can we uplift peers to do that training? How can we coordinate with, like, and think of it as the training as, once again, a whole system care approach whereby everyone is trained so that we can connect. And that's our goal. Yeah, thank you so much.
Thank you all. This is wonderful information. I know we are getting close to our time, so I wanted to make sure that we had enough time for some questions here before we give each of our presenters some time to give their key takeaways that folks should leave this meeting with. But I know we've seen a number of questions here in the both the chat box as well as in our Q&A section. So first, I really did want to ask a legal question from the sake of, I think there are a couple of questions about what do you do if your state does not have a Psychiatric Advance Directive statute? I know here in New York, we don't have a specific statute on Psychiatric Advance Directives, but we do have an Advance Directive one and some case law around that. But I did want to hear a little bit from both Marvin and Marjorie possibly about what folks should think about if their state doesn't have a specific statute and whether there are protections and a way to include a Psychiatric Advance Directive, even if you don't have a statute.
Sure. Thanks, Luke. I think my first piece of advice would be become very informed about your state's advanced directive statute, making sure that your preferences are written in or expressed in accordance with that statute. There was a great question in the chat or the Q&A about expressing your preferences through a video. And I think there's sort of, I'm of two minds with that answer. First, I would caution against relying on the video solely because in a lot of state laws, the document needs to be witnessed or notarized or, some other sort of execution there in order to hold legal weight. And I have not heard of a way to notarize a video, so I just would caution against relying on that by itself. That being said, when expressing your preferences, more is more, right? Like we've talked about the weight that these documents hold for purely informational purposes, for purely advocacy purposes. And I think being able to show who you are and what your preferences are in a way and communicate in a way that may not be available to you in the moment while you're in crisis has its own value. And so that's just all to say, I would rely on the existing sort of statutory structure in your state and just make sure that whatever you create is as close to that statutory structure as possible so that there is very little room for discretion or very little room for someone not to honor it simply because it holds psychiatric preferences and not medical preferences.
Yeah, I would jump in. I agree with, this is Marvin. I agree with Marjorie. And there's actually very few states that don't allow psychiatric decision-making within the Advance Directive statute or the appointment of the healthcare power of attorney. So I would encourage people to do that. There are some limitations. In some states don't allow certain decisions, but most do and should be an avenue to allow one to do it. The one feature that's going to be different is that the Psychiatric Advance Directive in the standalone ones are irrevocable, whereas generally the mainstream advanced directives are revocable during a crisis. So it doesn't have that feature, but otherwise I think that would be the best thing you can do in those states.
Thank you. We have another question here about the rollout of psychiatric advance directives, specifically in consideration of training. Zachary asks, is a rollout advised, or do you only suggest rolling out once all are trained, educated from dispatch down to community providers to hospitals? And then any suggestions in working with hospital associations or hospitals to be sure to honor the PAD, especially in rural areas where providers can't easily pass the case off to another. I did want to start with Marvin here, just to give us the sort of national lens as far as training and that rollout, and then get it back to Kieran and Rachel again.
Yeah, so we, in one of the surveys that Harvey mentioned that we did, we have found in the studies we've done is that people really need help in completing advance directives, because it is very hard to understand. It's not written out at a level that a lay person could readily understand. And so one key step is sort of translating the statutory language into language that people can understand. So that's where training, I think, is really important, because you want to help people do them in a language that they understand. But I also really agree with the comment that, or implicitly agree, that there needs to be a lot of education for health systems and for hospital attorneys, hospital associations. One thing that would help is if the Joint Commission on Accreditation would survey on this. They have not, that's not been a key part of their surveys, but they have tremendous influence with hospitals. And if they started to survey and asked hospitals what they're doing, I think it would jumpstart compliance. The thing I said about compliance, I know there's a little off the topic, but it's key to understand. I said that a hospital could lose its Medicaid and Medicare funding if they didn't comply with advanced directives. Unfortunately, those action only happens when there's a complaint. So it's complaint driven. So someone would have to call CMS and say, well, this hospital isn't complying. And it would be better if there was a survey to check on compliance than wait for complaints, because often, people don't know to complain, or they just don't know enough to lodge a complaint.
Thank you. And then, Kieran, just to wrap us up here.
When we look at that question of rollout, I think again, I think it's in multiple areas, right? Marvin is completely correct that we have this federal mandate, really. We have this, that no one is just asking, do you have an advanced healthcare directive? Great, they check a box. And then what? And I think that's, I think rollout is so many different layers. I think if it is an informational rollout, you have a training rollout. So I think it can be incremental. I think that most importantly, it's get the information out and train. So I think rollout has to be based on what each individual community is doing, and based on capacity.
Thank you. Our next question really is around the use of coercion and sort of force when creating psychiatric advance directives. There's a question really around whether these are people can be pushed into this. I'm going to have Harvey talk a little bit about thinking about these as documents for self-determination and should be against any decisions being placed on people, but rather should be allowing folks to create their own path in recovery. But Harvey, can you talk a little bit about that?
Yeah, you see the same thing, I think, with RAP plans and other things. There's this phenomenon where staff feel somebody should fill them out, and they influence people, perhaps a family member also. So I don't know what you do and how you monitor that, but maybe in the training and in the ethic that gets established, it makes clear that this is a totally voluntary approach, because you hear it all the time. I'm going to get him to fill out his rap or something like that. Well, you wouldn't want to hear that here as well. So yeah. And I have a question, Luke. I'm going to grab a leap here and ask Marvin. Marvin, did you say CMS has oversight over JACO having a survey about this?
I'm sorry, no. JACO is, independent, and
Is
it's a
it?
business in which people contract with them to do the survey. So yeah, CMS doesn't have oversight.
Okay. I thought maybe we can get Samson to action here, but okay.
Well, they could influence JACO. When we talked to them some years ago, when you were on our advisory committee, and I thank you for that, we did approach JACO, and their answer, we said, will you start to survey or do something to raise awareness? And they said, we just, there's so much to survey about this, it isn't at the top of our list.
Yeah.
Thank you. I think we have a couple other questions. One that I think is really important to pose to some of our trainers here. One question from Jonathan: what are the most salient and essential peer practices that could and should be used by peers to assist those filling out pads?
I think everyone else can lend to it, but I think since I've gotten a pad done by a peer and a lawyer, I think that I can come from the lived experience and then from the trainer lens. I think as somebody with lived experience, I think the best thing that I got from the peer was the peer listening, the approach that they just listened, because as it was noted, like Dr. Swartz said, that this document is a very hard document, and it was emotional to go through, to go back in time, and to have a peer there that was able to listen, to show mutuality, to promote self-determination, and all those are peer practices. And it lends back to that question about coercion. That's why I believe that a peer is most appropriate, particularly we have a training program like other states. We're probably one of the last states to have the peer specialist, but those core values and advocacy lend to the values and alignment with what we'd want to promote in someone using this self-determination tool. So I would say those things lend to the peer ethics in your states, are main things that really resonated with me as thinking through the approach in our training and putting together our training components, and as someone that received my pad with a peer and a lawyer. So I don't know if that lends, and I see a whole bunch of hands. So Luke, I don't know.
Yes, I think let's go to Kaylee.
Thank you. And Rachel, that's an excellent point that you bring up. I can definitely relate from the peer experience of creating a pad for myself. It was a very emotional process for me, especially in the revision. It took me quite a few weeks to revise it. So I think a big core value in this is coming at it from a trauma-informed lens, and being mindful that we do not want to create a crisis in the moment by preparing for the potential of a future crisis. So in that peer support role where we're able to see each other on eye level and talk through these things, I think that's very, very important in creating a pad. And again, being mindful that these can be difficult conversations to have and to revisit.
Thank you. That is really important to note there. And Marvin.
So I think Rachel and Keely are making great points, and I would just complement that by saying you have to think about readiness to do a pad, that sometimes people are just too fragile to do it, A, and B, one of the things that's really essential is that you're able to step back and think about what happened and how you would want it to be different. And so people have to be in the right place to do that. They have to have some perspective on their on past crises and be able to articulate that in a way that it's going to be different. So, to Harvey's point, not to push it, there's also, I think, the facilitators or the people that are doing the training need to be sensitive to when is a good time for a person to do it.
Luke,
Thank
do you
you.
mind if I just say something real quick with that?
Yeah, very quick.
I 100% agree, and I think that part of the challenge sometimes is maybe an individual can only fill out a little bit at a time, and so in order to get really rich information on an individual, you need quite a bit of their information, and I think making that space for them to be able to fill it out on one day or come back and fill it on another day, and just understanding that it isn't something to be rushed, because to Kaylee's point, it can bring up that same crisis feeling and those feelings that they, had in that moment. And so just being mindful and that's one of the aspects that we look at, in the digital world, which is so amazing, is you can save it for later. And so, but you can also save it for later in the paper form as well. So ultimately, it's just being sensitive to the individual in that moment.
Okay, thank you so much. I know we have a number of other questions in the Q&A and some of the chat. We'll make sure to address them and some of the information that we send out afterwards. But I did want to take a quick moment to, first off, thank all of our presenters. And then if you had one very quick thing that people should take away from this presentation, what you think that should be. And I'll start with Marvin and then go to Ryan here.
I think the quick takeaway is that we need folks in the community who will help, who can facilitate, and we need in every state a cadre of people that are out there who will help folks do them.
Ryan?
Yeah, I think my biggest takeaway I want people to leave with is just start having the conversations, start having the discussions, and that's where it really starts with.
Haley?
We deserve to have a voice, especially in our medical care, and we deserve to have a voice in decisions that are being made about us that impacts us more than anybody else in the world.
Kieran?
I think the takeaway would be advocate, advocate, advocate. We need to spread the word about directives.
Rachel?
PADS is a civil rights document, and peers leading the way with other crisis professionals can improve crisis and whole health care by working together.
Marjorie?
My takeaway is that knowledge is power. Educate yourself on the mechanism in your state for being able to advocate for your needs, whether that's through a PAD, a different type of advanced directive, or collaborating with the advocates in your life.
Last but not least, Harvey.
Well, advocate and educate, definitely those two. But I just heard there's more questions here. We could have a part 3, Julie, it sounds like. Maybe more to the point, though, is we should take these things and make videos on them in some way, and even more information about it, because this is really a time. I don't know, Marvin, if you've ever seen this amount of interest in PADS, but I never have. So I think this is the time to really respond.
Agreed. And it's exciting.
Thank you all so much. And Julie, I know we have a couple of last minute things here around feedback, and take it away for us.
Thank you so much, Luke, for your wonderful moderation. Thank you so much to all of our attendees for joining us. If you haven't already, please do share your thoughts on our feedback form. I've dropped it in the chat probably more times than you would like, and I'll drop it once more for good measure. And thank you again so much to our presenters for that deep dive into this critical topic. And thank you to C4 Innovations for supporting this event. Just a reminder that we will follow up with the recording link and also the PowerPoints so that you'll have that for reference. And yes, thank you again for being here, and wishing you all a wonderful rest of your day and into the weekend as well. Take care, everyone.
Thank you.